Good afternoon. My name is Sharice Magoon, and I am with UT Health School of Nursing. You are signed in to hear Kara Ann Waitsman present Getting Beyond the Diagnosis, Promoting Infant and Family Development Through Infant-Driven Care. We are happy to have you join us for the Texas NAS Awareness Month. These free CE presentations are sponsored by Texas Health and Human Services. Before we get started, I'd like to go over a few housekeeping items. If you can please make sure your video is turned off and also your microphone is turned off throughout the presentation. We will take question and answer via chat at the end of the session. Kara Ann has been a neonatal therapist for over 33 years in a level 3 NICU and serves as the nursery's development specialist. Kara Ann is president of Creative Therapy Consultants, founder of the Neonatal Touch and Massage certification, and former co-founder of Infant Driven Feeding. She is certified in NTMC, is pediatric neurodevelopment therapy trained, certified in NID CAP, and is a certified neonatal therapist. Kara Ann has received professional awards, including the National Association of Neonatal Therapists Inaugural Pioneer Award, the Ohio Occupational Therapy Pediatric Model Practice Award, the March of Dimes Healthcare Worker of the Year Award, and the MVH Excellence in Service Award. Without further ado, I'll hand it over to you, Kara Ann.
I'm excited to be with you here today, and I'm excited to talk about getting beyond the diagnosis, promoting infant and family development through infant-driven care. So first of all, thank you for the conference planners for putting this conference together and asking me to speak. I'm excited about this whole idea of June being NAS Awareness Month, and I hope that's something that we can make national over time so that all of us can increase our awareness of how to better identify how to care for these babies and families. The background of what I'm speaking about today with this whole idea of getting beyond the diagnosis is really part of my mission to help us all put humanity back in healthcare. Now, what does that mean? Seems kind of weird, doesn't it? But really, it's just the idea that we have so many opportunities from a technological standpoint in our intensive care nurseries, and it's awesome. We've had so many technological advances in the last 30 years that I've been in the neonatal intensive care unit, and I'm thrilled for those. But I also don't feel like that is the only means by which we can help our babies. Likewise, we've had a lot of pharmacological advances, and so we've got some great drugs to help take care of babies, and I think that's awesome, and I want us to keep doing that. However, I'd really like to put humanity back in our healthcare and make sure that as we're caring for babies, that we're also looking at relationship-based caregiving, and that we're paying attention to who that baby is, not just their diagnosis, but who they are. That when we take care of families, we're taking care of them as a family, an infant-parent dyad, and helping them become a family and to attach and bond and help them long-term, not to just make it through the discharge process so they can take their baby home. So this talk is really going to look more specifically of how when we take care of these babies with NAS, how could we better care for them from a relationship building humanity standpoint so we can foster long-term development. I go back to that idea of taking care of them and increasing that relationship-based caregiving from a technology standpoint. Sometimes we've got a baby who's crying and we turn on a mobile or we put him in a mama-roo. Technology is great, but if we have the ability to sit there and talk to them and sing to them and hold them and give them a massage and do some real true humanity, relationship-based building activities, that's going to promote development so much more than being in a mama-roo and swinging back and forth. Having the humanness of rocking back and forth is so much more valuable. As well as, if we've got a baby who's crying, we can go, do a Finnegan score and give them some drugs, or what can we do much more as a human to be able to help that baby find that consoling, and also not just consoling them, but realize that babies don't just eat, sleep, and poop. Babies eat, sleep, poop, and play. And play is how an infant develops. It's that ability to look, at themselves and discover themselves and touch themselves and identify what their body limits are, as well as their environment around them. And you are their environment around them. So let's get started. I'm excited to. So as I mentioned, the presentation today is Getting Beyond the Diagnosis, Promoting Infant and Family Development Through Infant-Driven Care. From a disclosure standpoint, I am president of Creative Therapy Consultants and founder of the Neonatal Touch and Massage certification. So in regard to our objectives, I kind of explained a little bit where we're going with this, but more specifically, we're going to talk about core measures of neuroprotective care that are appropriate for the neonatal abstinence syndrome population. We're going to identify 3 caregiving activities to promote infant development, as well as activities to promote parent-infant engagement interaction. To begin with then, I'm going to show you a video of a baby who is clearly crying, but what I want you to pay attention to is just the concept that when a baby is crying and in that state of crying, that they also have autonomic distress because they've got an increased heart rate and respiratory rate the longer they cry. And they have motor stress, they're flailing about, there's extension and abduction. And when they're in this stressed kind of autonomic motoric state stress, they're clearly not having homeostasis and regulation. Their heart rate and respiratory rate, even their digestion, all those things are outside the parameters where we rest and digest. And that parasympathetic nervous system rest and digest is where we also grow and develop. So in an effort to provide this infant-driven caregiving concept where we're going back and identifying who is this baby and how can I help them be all they can be, it's important for us to identify an activity as simple as non-nutritive sucking as an activity that can actually change not just their state, but their motoric and their autonomic subsystems as well. As you watch this video, I want to be very clear. I understand that not all babies, just by offering non-nutritive sucking, can completely settle in, but it is an incredibly powerful tool when offered appropriately. I think it's important for us to realize that touch is the mother of all senses. It begins very early with a baby as early as 8 weeks responding to gentle touch on the cheek in utero. And at 12 weeks, the babies are sucking on their thumbs and exploring the world around their uterine wall. And so we even know from Janet Diapetro, who's a developmental psychologist at Johns Hopkins University School of Medicine, that fetuses actually lick and have mouthing movements on the placenta. So they're exploring themselves, touching very early on, not just themselves, but the world around them. We need to remember that touch develops 100% exogenously, meaning its development is susceptible to the external factors like the environment of care that we provide. So how we touch or don't touch, that touch experience that we offer to the infant is what the position that you provide them, for example, it's hardwiring in their brain, and thus it affects later development. So touch is important not just for the touch system, but it has huge implications for development. And these are just a very few of the resources I've got listed from Maurer in 1988 all the way to Casico in 2018. We've known the importance of touch related to development forever. Like it dates back way before 1988, but we know that touch is important for things like human attachment, family bonds, cognition, fine and gross motor coordination, communication, and it's huge in emotional regulation. and you go back to that self-regulation that I was just showing with that baby and how non-nutritive sucking helps with that self-regulation. It's that whole idea that touch is important for our ongoing emotional regulation. So once again, this is not an exhaustive list by any stretch of the imagination of the importance of touch for long-term development. So as we think about putting this positive touch back in our healthcare system with, trying to provide infant-driven caregiving as the means by which we increase that humanity in our healthcare, then I think it's important for us to just recognize medical touch and social touch and how different our touch can be in the places like a hospital and intensive care unit. So one of the things that happens is our babies are in their cribs, in their rooms, whether it's an open bay or a private nursery, and sure, we go in there and we provide our care and then we leave. And are we talking to them a lot when we're in there? Are we touching them in a social sort of a way, or is it all just medical? Are we doing procedural touch? Are we just taking a temperature, changing a diaper, putting a bottle in her mouth? And I don't mean to make this sound like we're not taking good care of babies, because let's be honest, healthcare providers go into healthcare, nurses go into nursing, for example, in order to help people. But over time, we have a lot of tasks that we have to get done in our 4-baby assignment or whatever it might be. And we tend to become task-oriented, and we forget the power of putting that humanness and that social touch back in our healthcare. And so this whole idea of lack of social touch has really actually been looked at now more specifically, and realized that we can actually increase sensory processing disorders when these babies have that lack of human touch. And in fact, when there's a lack of social touch, there's an increased avoidance of social touch, which also then is a predictor of ASD, or autism spectrum disorder. And you can see these references from 2005 to 2015. We've got this information that's been coming together to show us how important this social touch is. We also know that in our intensive care nurseries that 95% of touch is not intentionally comforting. We've become very procedural. I'm not saying that these things that we do with babies aren't important in terms of the procedures that we do, but we have to look at how to provide 95% of our touch as being intentionally comforting. And I'm on a mission to change that through education. The reason is because in the absence of positive, all we have is negative. And I don't think there's a better time in our nation, in our world, to talk about the importance of social touch than there is today, when our world stands 6 feet apart from each other in an effort to minimize the spread of COVID-19. We're social distancing, and while it's arguably a good idea from a spread of infection standpoint, it's not without consequences. And likely everyone's awareness of the need to touch is very at the surface right now, because there's actually already been those studies that have come out that talks about how this lack of social touch is causing some feelings of isolation and loneliness and depression. So this Gagne study in 2018 is a study that was done looking at this idea of human interaction in the NICU, and found that it was actually associated with altered outcomes on the BITSI, the Brief Infant Toddler Social and Emotional Assessment. Now, this study was actually done with infants that are much smaller, the babies born at 25 weeks. But we did find that subjects spent 80% in the first month of life in isolation. And that, of course, nursing compromised the majority of human interaction. And so, by all means, when, as nurses, you're interacting with these babies, we need to make sure that it's very human. They also found out that the higher the human interaction was associated with higher social competence and lower dysregulation. So that these babies just did so much better when they had more humanness in their early caregiving. And whether you're born at 25 weeks or 35 weeks or 40 weeks, I think that that is equally important. And it continues to be important in those first weeks, months, and years of life. So I'm going to show you a video of what I see as social touch. I hope watching that video made you smile as much as it did me. And I think it brings us back to that whole idea that touch is important and that we need it for normal development, and that touch promotes normal development. And so that brings us to this idea of neuroprotective core measures that I mentioned I was going to speak about. These were actually developed by Leslie Altemeyer and Raylene Phillips a long time ago, and they've had several publications. I've just referenced the one here in 2016 in Newborn and Infant Nursing Reviews. Mary Coughlin also talks about core measures. And so whichever one you're looking at, it's this idea that these healing environment, minimizing stress and pain, positioning and handling, safeguarding sleep, protecting skin, optimizing nutrition, and partnering with parents are core fundamental values and caregiving that we need to incorporate in our intensive care unit. And I would argue that these are things that we need to incorporate in our human life, and that we need to teach parents this from the beginning, because it's not just about being in the NICU, but these are actually great core measures for beyond the nursery. And so we're going to move through and just talk about a few of the activities within these categories that we can provide that will help these infants and families grow and develop more optimally. So the first core measure is healing environment. And I want to propose to you that the very best place for all of our babies in a nursery, and that doesn't exclude the babies with NAS, the best healing environment for them is skin to skin. You guys, there is so much evidence-based support for holding babies skin to skin. And we often talk about it in our nurseries in terms of the small babies and the micropreemies and getting them out to hold and all of that kind of a thing. But we forget that this is just also something important for all of our babies at birth. Hopefully, if you're a birthing hospital, you're bringing that baby out and putting them skin to skin in those first moments and hours of life. But it shouldn't stop in the first 2 days of life. The World Health Organization reports that we should be promoting skin-to-skin holding for our preterm babies for up to 6 months, and in our term babies for 3 months. When we talk about holding with our NAS babies skin to skin, one of the first pushbacks and kind of defensive mechanisms that I hear from healthcare providers is, well, yeah, the parents are never here. And trust me, I get that. But I think part of the reason why they're not there is because we don't set them up always for success from the very beginning. Now, many of us do, and so I'm not, once again, I work in the real world in the intensive care nursery, so I'm not going to sugarcoat anything. We've got teams that really understand this and promote this and do well, and then we've got other ones of our peers that don't. And so how can we help all of us do this consistently? Because when you're trying to hardwire a brain, it takes practice to make things permanent. Doing things every now and then isn't the way to create a neuronal pathway for later developmental outcomes. It needs to be more consistently. And so we want all of our healthcare providers to realize that when we're supporting a mom and a baby, skin to skin is where they need to be, and or daddies and babies. So this whole idea of having a mom or a dad be here more often might be because we need to start in those first, days, hours and days that they are present because they've just had a baby and they haven't left the hospital yet. How could we help them know and understand and really believe in the culture that if they do skin to skin frequently with their baby, their baby's more likely to wean off their meds quicker and or not have to be put on meds. They're more likely to go home. They're at less risk for infection. That if they're planning on breastfeeding, that mom's going to have an increased milk supply. That it helps with attachment and bonding long term. And that the World Health Organization says, and the AAP says, let's do this for a full 3 months with these full-term babies. And so how can we help you prepare to do this once you take your son or daughter home as well? So it's this whole idea of really helping our parents learn that, according to the, for example, the Sharpak study that was done in 2017, it was a 20-year-old follow-up for moms who had done Kangaroo Care skin to skin. And when they contrasted those kids at 20 years of age, they were able to identify that those kids actually had better self-regulation, that when they were stressed, their cortisol levels didn't change as much. It goes back to that crying baby I showed you a while back. When we're stressed through life, we actually have that ability to then bring in that self-regulation more. When we've done skin to skin, that study was just an hour a day holding for the first 14 days of life. I understand that these family members need to go out and maybe smoke, and or they're working through crisis. They've got all these things going, and so it's difficult for them to sit for a long-term period of time. But if we can get them to sit for a while with their baby wrapped in a wrap doing skin to skin, then I think that's super important for them to feel that oxytocin release, which is exactly what happens, that happy hormone, and help them start feeling that comfort and that attachment and bonding that physiologically happens during skin to skin. The second core measure then is minimizing stress and pain. And so this is where I want to caution you that we shouldn't be using things like sweeties on a regular basis, the sugar water, in order to try to calm these babies, because these babies a lot of times are not in stress unless you're doing a stressful procedure for them. And so there's some gut mechanisms in the thoughts that we shouldn't just be using that unless the baby's actually in pain. So that's step one. But how can we minimize their stress? How can we hold them and handle them and position them and care for them and create an environment by which they are less stressed? And there's lots of answers to this, and I'm going to do some demonstration with a doll in a few minutes about how to do some of these activities. But first of all, I want to talk about sensory memory and the idea of what senses do with these, the interpretation of sensory experiences that our babies have. So one of the things we know for all babies is that when sensory input, noise, light, smell, touch, taste, movement, when that sensory input comes into a baby, then their amygdala decides in that moment, is that happy and awesome and safe, or is it scary and dangerous and awful? And that identification of one way or the other, it's two ways that they can decide, good or bad, safe or not safe. That then information is then going from the amygdala to the hippocampus, this whole insular area cortex of our brain, to identify as an emotional memory. So essentially, that information is stored then as good or bad. And so it's important for us to realize that if we've got noxious touch, or if our diaper changes and handling and dressing and bathing and IVs or medication or isolation or all the things we're doing with these babies is not interpreted positive, then it's all just negative. And in the absence of positive touch, all we have is negative. In the absence of positive experiences at those beginning life periods when we're creating those neuronal pathways, then wires that fire together wire together. And so neuronal connections then start anticipating negative touch experiences, and we end up reacting defensively to all touch. And it's interesting when you go back to those studies I was mentioning about, for example, autism spectrum disorder, and that whole idea of social touch and the lack of social touch promoting more lack of wanting to be have social touch. It all feeds into this amygdala hippocampus standpoint. So we need to start looking at what kind of things we can do to really make sure that we're providing a lot of positives, because in the absence of that, all they have is the negative. And I know no better way to do that than neonatal massage. So this is just a list of some of the benefits of neonatal massage. And while in this population we're not always that concerned with weight gain, certainly some of the babies have problems with that. And just looking at things like bilirubin levels, and there's a great study that just came out actually very recently in 2020, I believe, maybe it was the end of 2019, looking at TCB results and the significant improvement when babies are massaged, that they just are able to, potentially this baby with NAS won't have to go under a light, which is a blessing, right? Decreasing stress and pain, improved brain maturation, and this is what I'm talking about, those neuronal connections that help long-term later development. Improved sleep. We're asking these babies to sleep and they have a hard time, so give them a massage and help them get into that sleep. Help them get in that parasympathetic nervous system with a heart rate and respiratory rate that are more in that homeostasis. Immune function, because of those killer T cells on the skin that we're massaging. Temperature stability and regulation, improved muscle tone, improved neurological development, better outcomes with eating, efficiency. So all of those things are things that are certainly at the core with our NAS friends. And then I love this whole idea of enhanced parent-infant bonding, because there's so much importance with that. And then, of course, decreased length of stay. So neonatal massage is one of the most awesome ways to minimize stress and pain, and it certainly goes back to being part of a healing environment.
Look at your tight little muscles going on, sweet boy. No, look
You
at
can't see that.
Oh, yeah.
It's okay.
Look at your tight little muscles going on. And forming, and I'm just going to show that his muscles are like not bulging anymore, because it's a huge difference. That's a boy. And that space between his neck and
Yeah,
his
he's not so
shoulder and
crunched
his
up.
head. Yeah, he's got space between his ears. Beautiful. And then I'm just going to do it. All right. And form.
So that first clip was of a baby that we had just put on his tummy to teach parents how to do some neonatal massage. And we're talking through, you saw all of those tight paraspinal muscles. The baby's lifting his head, and we need to help parents realize that that's not head control, that's musculoskeletal tightness. That's that increased tonal response that we get from NAS. And then you saw that quick little clip that was just literally 7 minutes later, that baby was just in the most beautiful, quiet, alert state, with none of that musculoskeletal tightness and increased tonal responses anymore. So there's so much power in neonatal massage, which leads us beautifully into this whole idea of positioning and handling, which is the third core measure I want to talk about. So the principles that you really want to remember are flexion, containment, alignment, and comfort. Whether a baby is sleeping in an infant seat, having a bath, eating, doesn't matter. Flexion, containment, alignment, and comfort is going to bring this baby in a more parasympathetic rest and digest kind of a place. We also want to remember that movement is important, and that just, swaddling them tightly in a blanket to where the baby doesn't have any movement 24/7 isn't going to be good either. We want to provide containment, not restrainment. So having this baby's ability to move and giving him opportunities and putting him in positions to facilitate movement patterns is vastly important, because remember, they're playing. They're developing. They have to learn about their body, and they can't learn if they don't have the opportunity to move at all. And so we need to engage them in these activities: visual, auditory, touch, movement. Engage them in smell and taste with, putting the pacifier in the milk so that they can have those tastes along the way, not just when they're eating it, but they can taste it as a comforting activity. Lots of tummy time, and teaching parents how to do tummy time so that they can have that movement and that development and normal positioning to help set them to the next stage of development. Just like this idea of supported sitting that I'll show you, to help these babies know that we can help them lean forward and start to have head control and engage in their environment around them. Teach them, help them learn how to play so that that play facilitates the next stage of development. The fourth core measure then is safeguarding sleep. So it's that whole idea, let's not wake a sleeping baby. And I think about that many times when we talk about medication schedules and how literally sometimes they've been awake for 2 hours and 45 minutes, which honestly, depending on how old that baby is and what the circumstances were, might not be that atypical. It doesn't mean they need to do that every time, let's be serious, but it could be that that baby then just had an alert period in the middle of the day or the middle of the night, and that's okay. But we need to make sure that otherwise this baby is sleeping well. And with medication schedules, sometimes the baby's been awake for 2.5 hours, and now we're going to wake them because it's time for them to get their medication in the next 30 minutes, and we got to go through our process. And so that's where I go back to that infant-driven caregiving and realizing that if they get into sleep, let's let them sleep, and let's safeguard that sleep pattern. But let's also be in awareness that babies don't just eat, sleep, and poop, but they eat, sleep, poop, and play. And so if we play with the baby, if we do some of the things I just talked about with tummy time and supported sitting and engaging them, then it's like they've gone out for a walk, they've had some activity, and they're going to sleep better. We all sleep better when in the end, we just haven't been a couch potato all day. And so we need to help these babies engage in life and learn about their environment for normal development. And the same goes with parents and helping parents understand that sleep-wake cycle and, when it's okay to wake up a baby because they haven't eaten in quite a while and when it's not. Really important. The fifth core measure then is protecting skin, and probably one of the first things I think about with skin with these babies is their increased diaper dermatitis that can happen over time. And so, this crying baby on the right makes me think of a baby who's having a diaper change. And so not just protecting their skin, but how can we change a diaper in a way that will help this baby not be flailing about and have all of those, sympathetic nervous system response reactions to the touch experience of changing a diaper. And so just kind of thinking through that, as well as bathing. I think bathing can be a great skin protecting idea, and wiping away any germs that might cause some issues later, but also doing so in a way that can protect the skin, realizing these kids have not been playing in a sandbox, so they don't have to be scrubbed, so to speak, but that we want to do all of these caregiving activities, flex contained, aligned, and comfortable, in order to provide that more neuroprotective and neuropromotional kind of caregiving experience for these kids for long-term development. Our 6 out of 7 core measures is optimizing nutrition. And I just want to, I've got this picture of this mom breastfeeding because, and I think you've already probably had a lot of lectures within this conference about hopefully breastfeeding and feeding. And so I'm not going to spend much time with this, but I do want to mention this little baby on the right who was just saying, oh my gosh, are you kidding me? Please, not another nipple. So many times our babies with NAS are having complete regulation problems, and they're a mess, and they're having a hard time eating, and then we go get another nipple and another nipple, and we think it's a nipple problem. Really, it's a self-regulation problem. And we really need to do some caregiving activities to help bring this baby back into homeostasis as much as possible, and then help them eat. It's hard when you are crying hysterically and your heart rate is sky high and now you're breathing fast to coordinate 26 muscles and 6 cranial nerves in 1 second in order to be able to be efficient with the suck, swallow, breathe pattern. So many of these babies too, they get their necks in a backwards position, in occipital extension, and then we're trying to feed them in a musculoskeletal abnormal, atypical position, which makes it difficult to eat effectively. And so they don't need another nipple, they just need to be put back in alignment. And we're going to talk a little bit more specifically about that in a few minutes. So partnering with parents is by no means actually like the last of these core measures, but I actually moved it in this list by Leslie Altemeyer and Raylene Phillips to the bottom because I feel like it's foundational. It's that you need to make sure that parents understand the previous 6, and then that just makes this 7th one just obvious, because parents need to learn about healing environments and safeguarding sleep and optimizing nutrition and minimizing, stress and pain, and the importance of positive touch and all of those things. So parents along the way need to be our partners, and we need to help support them as the superheroes they are in creating superheroes. It's this whole idea. When I saw this picture, I was like, that's what I want us to communicate to every parent, that they can be their baby's superhero and that they can help their babies turn into superheroes. We can all help this family be all they can be when we've got the mindset to do so. And that we start with helping parents learn how an infant communicates. What are the stress signs? What does flailing about mean? What do big eyes mean with eyes raised eyebrows when we're trying to eat? What does it mean? What is a stop sign? What does a coming together inflection and bringing their body together mean in that self-regulatory sort of a way? How can we help these parents learn to do neonatal massage and in a listening touch sort of a way, and skin-to-skin holding, and the importance of swaddled bathing and tummy time for later development? Helping them learn how to put their baby in a supported sitting position to work on visual and auditory and head control. And how can we help them with their diaper changing and dressing and undressing in a way that helps it be a fun, engaging activity instead of a stressful activity for both the parent and the infant. Helping them realize and recognize the feeding readiness cues, and identifying when their baby's actually hungry as opposed to in pain or have a wet diaper. So these are all important ways that we can help our parents partner with their infants, and we need to partner with the parent so the parent can partner with their infants for not just discharge, but for long-term infant and family growth and development.
Okay, so tell me about your son Jordan and why we were doing some massage with him and why you wanted to learn at massage.
Well, this would be my first child, and I've never been, I'm anxious to learn stuff about, how to bond with him and anything that can help him. So when I learned about doing the massage with him, and when I saw the results of doing it, it was amazing, like the difference between before and after, and it made me feel good because I could do something like that with my son. And it was bonding for me, and to be able to do something contact like that and close with him, I really enjoyed it.
Great. And then tell me about Jordan's response to it. How did he respond to the massage?
Well, at first when we started, it was like you could just see every single muscle in his body, and he was just balled up and not real happy. He was fussy, and you can just tell within a couple of minutes of starting that it's a total change. He lays out flat, arms, legs are totally straight. His neck, like before he didn't even have a neck, and then afterwards it's like he's just so relaxed. You can just see that he enjoys it so much, and that he feels so much better after you're done. And I really did enjoy doing that with him, and for me to be able to do something with him and make him happy like that, and to see the change before and after, that's something that I'm going to continue to do because it's good for him and myself both. I really enjoyed that.
That's great. And so would you recommend other parents to learn how to do infant massage?
Oh, I would recommend it to anybody to do that. And if you're wanting to bond, or just be able to see the difference in your child before and afterwards, and see how much they enjoyed it, it's like once you do it once, you're always going to do it, because you see the big change, and you can't help but want to do that all the time, so he feels like that all the time. And I mean, it was amazing, the difference. And no fussiness afterwards. I mean, he was just ready for anything, it seemed like. I mean, everything was just so much better for him afterwards. Even his attitude had changed. It was like it was 100% difference.
Awesome.
So I hope you found that dad as adorable as I did in listening to him. And just the setup on that video was that we had just taught him for the first time, him and the mother of his child who had neonatal abstinence syndrome, how to do some massage. And so afterwards I just sat down with him and asked him these couple questions. And it was just so eye-opening. And I hope you really appreciated his responses to learning that, activity and how powerful it was for him. I want you to remember that in this whole idea of infant-driven care that I'm asking you to do, to really pay attention to who that infant is, who that parent is, help them mesh together for this, normal development. And I think this picture of these two babies is just adorable, showing their, their socialness and their engagement and their head control and all of those kind of great activities here from a developmental perspective. That's what we're looking for. But I also want to point out this picture of this healthcare provider. It's not easy, friends. It's exhausting. Sometimes 6 hours into your 12-hour shift, with having a baby who's cried a lot, you're just like, are you kidding me? I don't know what else to do. So I think it goes back to remembering that we are a team, and that we need to also, have that relationship building activity with our peers and helping kind of each other out in these times when it's tough. It's not easy. We're there to help infants and families come together as one, and that's exhausting work, but it is one of the most rewarding things you will ever do in a day. And so I just want to acknowledge that none of what I'm talking about is easy necessarily, and it develops a skill over time. And so one of the things I want to do next is show you a video of me just working with the doll. We're going to call Sarah, and just looking through with some handling and some tips with some of the caregiving activities, the infant-driven activities that I've just talked about, in a more skill sort of a way to learn some of the techniques.
Let's just pretend like little Sarah is here, and as you can imagine, she is screaming and flailing and arching and pulling backwards, and you walk into this screaming child who looks kind of like this backward C position, right? And she's flailing about. So what are the things that you could do to help her be happy? Clearly, she's in state stress, she's in motor stress, she's in autonomic distress because her heart rate is high, her respiratory rate is high, and so she doesn't have good attention and interaction because she's just flailing and screaming and arching and getting herself more and more into a sympathetic nervous system response. So what can we do for Sarah? One of the first things we might do is offer her non-nutritive sucking. And in fact, what we might do is dip that pacifier in a little medicine cup with some formula on it or breast milk on it so that we can have a little taste. It is amazing what taste and smell does for babies. And so not just sucking, which is the number one self-regulation activity, but also having that dipped pacifier. The next thing I'm going to do is give her frontal pressure because she's got herself extended, and we know that flexion and adduction help us come back into self-regulation. So I'm going to bring that arm around as much as she lets me, and she might be, arching back and fighting. I'm going to get my finger here and I'm going to bring her on her side and or tummy and start working on this pelvis a little bit. If in fact this pelvis is completely back like this, her head's going to be back like this. If I can help this pelvis tuck like this, you can see even with my doll how she tucks. So it's all about where the pelvis is, has a lot to do. So when I come here to hold her, for example, I might come like this, bring her around. And do you see how I'm helping this pelvis, not just like bringing the legs up, but helping turn this pelvis so this baby's in a different position. I might have to keep her side lying at first to provide this nice pressure. But notice the alignment of this baby's neck. I am not doing this to where her head is posterior. I'm going to bring that arm here to help cradle this baby and help her be in a very tucked side lying position with the head forward. Her chin is closer to her chest than it would be if it was like this and arched backwards. So we've got her like this. We're giving her some frontal pressure. I might then give her a few ups and downs, right? Some vertical rocking with the non-nutritive sucking, the frontal pressure, the pelvic hold for flexion. You will be amazed at how often one or all of these things take a screaming, crying, arching, sympathetic nervous system baby into this beautiful little drowsy or quiet alert, completely self-regulated now baby. The other thing I might have done is when this baby was originally here and arching and just, throwing her fit and everything, distraction works with all of us as humans, and it certainly works with a toddler, and it works with an infant. So sometimes when I walk into the room and I hear this, like the first thing I'm doing is, "Oh, Sarah, you got yourself in a mess. Let me help you." And if my voice, is soothing and awesome, or I might go, or I whistle, like I can't whistle, so I have to use that other sound. But sometimes that's like, "Oh, what was that?" And they completely like just take a breath and they stop their hysterical crying and they turn toward the sound because it's a different sound. Hi, big girl. And I can provide some deep input into her frontal pressure system here. I can bring her around, sit her into an upright position. Hi, sweetheart. How are you today? I want you to notice where my finger is. So I'm bringing these shoulders down and giving some input. I'm giving input here. I am not doing this. I'm not doing that Vulcan grip on the back of the head. I'm not giving pressure here. Because when people do that, the babies arch backwards. We would all do that. You get hit on the, brought in the back of the head, you're gonna arch back to it to push it away. So I'm intentionally making my hand very big. I'm holding her by her trunk. I'm mostly holding her by her front side. And then I've just got a finger here and as high as possible, so not here, but high as possible to bring that head a little bit forward and help those muscles relax a little bit. This is a great way to then interact and talk with this baby. I might bring her back into this position. Notice what I've got is kind of a modified side-lying upright position. The other thing I want to mention is that babies should always be able to come all the way forward and touch their toes with their mouth, essentially. That's normal. Babies shouldn't have so much musculoskeletal tightness and tonal problems that their head is back, their arms are back, and their spine is so tight that they can't fall forward. So if your baby has this problem, we need some massage, we need perhaps some therapy, some myofascial release, some trigger point releases from your therapist, that have maybe gone through NTMC to be able to learn those techniques. But either way, this is not okay. This is not where a baby needs to be. And so they've got literally some musculoskeletal tightness or tonal problems and some pain that can be associated with that, with their movements. And here we are trying to move them and they're screaming. We're trying to dress and undress and they're crying. And it's not because they have NAS, it's because they have musculoskeletal tightness that has happened during that period of time, whether it was from in utero or whether it was from our positioning here at the hospital or wherever we are. The same thing happens with that tightness that makes the head go to one side or the other. So one of the things I want to make sure that you're paying attention to with these babies and all babies is that you're making sure from a head molding standpoint and an interaction standpoint that we're doing the right thing to help the baby engage to both sides. So we want to teach these babies, we want to actually teach the caregivers. So you and parents, we want to make sure that we know that little Sarah has got her head to the left right now, meaning she's on my left side, I'm right-handed, and this makes it super easy for me to change this diaper. However, what happens with her is because I'm always coming from this side, her right side, she's going to have a preference to have her head to the right because she's going to look at me, she's going to listen to me. Even just that little bit of auditory in this ear more is going to help her or make her tend to want to go to this side. And now we've got a little bit of a shortened sternocleidomastoid on one side, it's elongated on this side, and we're getting a flat spot right down here on this side. So we always want to make sure then that next Sunday we make sure that we change her head of the bed. So that next Sunday she's actually having to look now to the left side to engage with me when I change her diaper and when I take care of her instead of to the right. That will help this head flattening problem. It'll help this sternocleidomastoid so that it's not always tight or shortened or elongated, because we're going to make sure then that we've had an opportunity to be on both sides regularly. Another way to look at that is that sometimes these babies tend to get ear to shoulder on one side more. So when you put them in supported sitting, they tend to fall one way or the other. So you can see that her chin is closer to this nipple than this nipple, right? If it was in the middle, it would be equal, but she's falling to one side. And that's of course a problem because all of these muscles are tight, this gets put up, and you have flatness back here, and you have more of a tendency then to have to look in a different direction. Sure, you can still turn your head to see both things, but do you see how she turns her head this way? Her ear is closer to her shoulder on this side. So once again, this might go back to needing some therapy, but it can all kind of go away if we pay attention at birth to help her maintain that more natural alignment, get rid of that shoulder elevation that can occur from withdrawal, right? So as a baby's screaming and hysterical, of course they're going to bring their shoulders up and they're going to go to a direction where they've been habitual in going, and that might have started in utero. So from a plagiocephaly and a torticollis standpoint, we just want to pay special attention that we can do ear to shoulder on both sides and that we can do chin to shoulder on both sides. Doesn't need to be performed in a upright position. You can do that same thing here and here and here and here. Now, keep in mind, this is a doll that I just showed you those maneuvers. We would not take a baby who's crying. If I start to go like this and she starts screaming, it could be that that hurt because she's got musculoskeletal tightness. And so let's make sure that we're engaging her. I'm trying to turn her towards me. I've got eye contact. Hey, sweetheart. Brrr, hello, big girl. Can you come this way for me? Oh, that's such a big girl. Thank you. And so realizing now we've got a bigger distance between ear and shoulder here, and then going to the other way and engaging her on that side. If she cries and screams, we're making it worse because she's shortening those muscles and making it, to turn. She might elevate this shoulder and kind of turn her body because she can't separate this ear with her shoulder. So these are all super important things to pay attention to. So one of the things that, in picking babies up, we tend to go from this. And you can imagine then what happens. Just as I went to pick this baby up, her head went back 10 degrees. With 10 degrees, you get a Moro reflex, a startle reflex, and then that's going to facilitate tremors. And then we're scoring her for tremors sometimes that really are caused by our caregiving. And so when we pick a baby up, please, oh please, give them frontal pressure, roll them to the side, and bring them up with the pressure in the front versus just from the back. And so, I always teach parents and caregivers how to hold and carry a baby here. If this baby is all archy, I might be providing this to continue to bring that pelvis in. I can use my body to help bring her into a more rounded position versus this backward C position that she starts with. So I might be able to do some massage strokes like this, just one-handed, just to help those paraspinal muscles that are so tight just come down so her head can fall forward at that time. I've got my pacifier in her mouth. I'm giving her that frontal pressure, being careful where my finger and hand placement is, and coming like this. So let's think about then changing a diaper. So I'm going to put her back down, and notice I don't just put her back down. But when I'm coming, I'm always moving her from a nice flex-contained, aligned, comfortable position in prone or side lying to that on the bed. In side lying, I'm going to continue to give her pressure here as I roll her back onto her back so that maybe we can change a diaper. Now keep in mind that, you know, we don't want to just lift up the feet and do Trendelenburg and have them flailing about, because once again, look what happens. My head goes back, I'm stressed, and I'm doing this. We could keep this part all swaddled with our blanket, right? So if she was previously wrapped, we could actually have kept this part swaddled and wrapped like this to provide this containment. So we have two hands, because it might be this baby has some diaper rash. We also don't need to do this. We can, you know, as we're keeping this baby flex contained, aligned, and comfortable, as much as possible, you can see that I might roll this to the side. Rolling is always awesome for babies because it helps with that pelvic flexion. I'm moving off to the side, and now I can get my other diaper, get my supplies I need from a diaper dermatitis standpoint. I'm going to bring this up and support the pelvis as I bring this up, not just pulling it up with the legs. Come around, and of course then I'm going to, you know, do what I need to do to change this, clean the bottom, do my wipes, whatever your protocol is. Clean. I have gloves on, blah, blah, blah. I'm putting cream on, whatever that looks like, after I've dried the bottom, and then bringing this back around. And in doing so, making sure I'm not putting the diaper on too tight. I don't need to cinch it like this, friends, because that's cutting off a uretropelvical kind of diaphragm there. So I've got it on. I might have it tucked underneath the umbilicus. If it was a boy, we pointed down, all those regular kind of things. But the thing is this baby was able to maintain a quiet alert state or a drowsy state much easier because she provided with flexion, containment, alignment, and comfort during that caregiving activity. The whole time I'm doing this, I'm talking to her, I'm engaging her. I might potentially have a mobile going, but really if I'm in the room, I want to be a human relationship with her as opposed to using the mobile. I can use the mobile when I have to step out of the room. And by room, whatever that looks like, whether that's an open bay or an individual room. So let's talk about how to swaddle her. So here we go. We'll just, once again, I'm rolling to the side to get the back of my outfit to then. I'm purposely using my forearm here to provide that kind of extra containment and pressure on her chest. I am not pushing. I'm simply giving that presence. It's presence, not pressure, really. So if I was going to come back around, once again, I'm not going to just like go like this and then watch her flail. If she was tucked like this, I'm always just replacing the blanket with my hands, right? Up like this. And if I was then going to re-swaddle her, I'm going to come around, I'm going to lift her out of bed, I'm going to get my blanket in a nice, you know, regular position where we square it off and do all of that. Let me turn it to the side so you can see a little better. I'm coming back down, bringing my baby around, move her down so you can see her. I've maintained this hand position the whole entire time. And then what I might do is bring this pelvis up, give some pelvic flexion, and bring the legs first around like this. Now my baby doesn't bend totally well here. Come around like this, maintaining that flexion, and then coming around like this. Notice I keep my hand here when I'm tucking this in, and then I've got this nicely wrapped baby. If I was going to put her down to sleep, I'd make sure that this blanket was nipple level and down, or of course I might be using a sleep sack. Either way, I'm going to show parents how to do this because they're going to need to know how to swaddle. They're going to need to know how to do this caring. They're going to need to know how to do this nice little firm but gentle pressure. You all are going to need as well to know how to bring the pelvis in flexion like this so this head can come forward. We're all going to need to know how to bring this baby up close to me. I'm giving some nice pressure here or presence, and I'm doing my vertical rock, right? Slow and gentle. That's a big girl, Sarah. Settle down. You'll be okay. Let's come a little bit more forward. That's a girl, Sarah. Thank you. That's so nice, right? We might be in a sleep sack instead. So the beauty of the sleep sack is while I was changing that diaper, we've got those little wings on that could keep this baby contained while we're down here changing the diaper. So let's move to another activity. I'm mom and I'm wanting to do some skin to skin. So I'm unwrapping my little sweetheart. Of course, we're going to take the clothes off, but just for a time saver here, I'm just going to leave the clothes on. So I've got her all great. We're in a good position here, right? Look at my handling. We're always side or prone. We're never just being held on her back like this or, you know, like this. Always self-regulation, flexion, non-nutritive sucking, nice pelvic positioning as much as possible. And then maybe I'm going to do skin to skin, and so of course I'm going to use a wrap. And so in doing so, let's see if I can move this so that we can see here. All right, so I've got my little girl up here, and this might be something for sure that I might need help with, especially the first several times. But the beauty with, you know, having a wrap and having it Velcro and all that kind of stuff is I've got a lot more ability to do it myself. So let's see. I'm going to bring this a little bit closer and down so you can see better. Yes, I'm in my kitchen, by the way. There we go. So you want to make sure that your wrap is tight enough that this baby is completely contained up here, because the whole point of the wrap is to keep this baby safe and secure while I'm holding the baby. Keep missing my mark. There we go. It's easier to do when I'm looking at it and not the camera, to make sure I have you on camera. I likely would even bring this up like this so that you can see her like this, and I'm hands-free, and now I can lay back, recline in the chair, and do some skin to skin holding. Of course, I wouldn't have my bra on. I might have my shirt over top or whatever, but no bra, because this baby just has a diaper on and we're doing skin to skin, right? It's a beautiful thing. Moms aren't going to do this until we let them know how awesome it is, right? And we talked about the research with this and how they're going to have to go out for a smoke break. That's all right. Have them come back in. They might need to wash down. They might need to put on a hospital gown so they don't maybe smell as smoky, but that's okay. Either way, have them go back to then holding their baby skin to skin. And then just to, you know, undo her. Mom needs to go out for her smoke break. You've taught her all of these things of this nice supportive pressure I'm giving. And now I'm going to just come back up. And once again, I'm not going to just lay my baby down like this. I'm going to come like this, right? Give that frontal pressure, come to the side. I might then put my baby back in the sleep sack or whatever it might be to help them go back to sleep. Another thing we might be doing then with our little friend Sarah is maybe give her a bath, right? And so a great way to do that is by immersing her in a tub bath. So whatever that looks like, so whether you have some kind of a, you know, bathtub like this, that's, you know, a Tupperware bathtub. We've got the liners. This happens to be the Dandel tub. It's got the plastic liner in it. So from a infection control standpoint, our hospital is thrilled about that. And keep in mind, if I am going to put this baby in a bathtub, I'm always going to have her swaddled, right? And so that might be a swaddle cloth like this, that once again, just like the skin to skin wrap, we have our awesome volunteers make for us. It's got a little pocket in the bottom of it. Wrap this baby around like this, or I might just be using a regular, very thin blanket. So a lot of the hospital grade blankets are just too heavy for this, but I'm going to put the baby completely swaddled into my bathtub. Now this tub actually comes with a sling to put in it like this, and it works great for the smaller babies. If it's a big baby like Sarah, I can just use this tub in this sort of a way. I might end up putting, let me show you, sometimes I will put a little something right here, but the idea is that this baby is completely immersed in water, like up to the nipple level, water everywhere. Her head is sticking out, but she is completely immersed in water because it's like this nice little warm bath for her that of course is going to help that musculoskeletal tightness. And this containment is necessary. Notice my frontal pressure through this. I've got her pacifier. I'm likely going to pull out an arm, wash it, tuck it back in. Pull out the other arm. I don't know whether you can see, yeah. Wash it, tuck it back in. You know, we're going to do the belly, and let me pull her out so you can see the beauty of this wrap is it's got a little V-spot, so I can do this. I can bring out a leg. I'll go this way so you can see better. Keep in mind she wouldn't have her clothes or her diaper on. But then when I'm ready to do the bath, for example, I'm going to come here, I'm going to bring her around, go like this, put the soap on this. This is my washcloth then. I can put her down to rinse. And then the big secret is when you take her out of the tub, you're going to have a blanket perhaps that you have up on your chest to wrap her in. You're taking her out of the sopping wet wrap in the tub and bringing her up to your chest here, right? And so flexion, containment, alignment, and comfort the whole time that we were doing that. You might have a bigger tub. So classic, I don't even know what brand this is, but I'm not into brands. I'm into just showing you anything you have and realizing that how you do this is what, you know, you want to teach parents how to do this. So notice when I'm putting her in here, I've got her swaddled in here. I'm going to bring her down into here like this. She's in the tub. Hopefully you can see that. And once again, make sure that water comes up plenty high. You don't want the water so that she's this far into it and just the back part of her is getting a little bit wet. Babies get cold easily with that. Once again, frontal pressure, I can do my wash, I can do all those things. The same thing, I'm going to come this way, side and up, put my soap on, wash, and then when I come back out, it's the same thing. Keep in mind, I didn't mention it when I had her in the bathtub, but you can do, you know, like some massage strokes and things while you're in the bathtub with the soap. So just from a massage standpoint, you know, I'm not able to show you a lot at this point. It requires some special training to really learn all of this and why you do what you do when you do. But, you know, some firm but gentle pressure down the paraspinals, as I mentioned before, is a great way to just kind of begin with this whole concept to help these babies relax a little bit. Keep in mind that you're always trying to facilitate flexion, containment, alignment, and comfort. This is going to help that baby sleep. This is going to help that baby eat better because her head's going to be in a good position. You know, she's had that opportunity for non-intuitive sucking. And once again, look at my handling. I'm not doing this and moving the head around. I'm just supporting the baby and giving that little bit of, you know, support here to help this head be in the right position because we don't want the baby's head to be here and then try to swallow. So everybody do that for me. Look up at the ceiling, look way up, come on, and now swallow. And how did that work out for you? The other thing is put your head off to the side, put your chin to a shoulder, and now swallow. Do you see how that's not comfortable? And so we need to make sure we help our babies get in good alignment when they're not eating so that when they are eating, they don't have so much musculoskeletal tightness that this is normal for them. Well, then that makes feeding awful, and then we score them for bad feeding. They don't have a feeding problem. We've got to put them back in alignment, and the care you provide all along helps with that. And once again, you might need a touch massage therapist, certified therapist to help with some of these techniques to help get them back. But if you pay attention to these from the very beginning, they shouldn't get so tight to start with. So the next thing I want to just review is we mentioned that babies need to play, and all the activities regard to swaddled bathing and massage and skin-to-skin holding, those are all ways that babies play, and even the handling and positioning that you were doing. So being in those different positions is movement, and movement is happy, and you know, otherwise they're just like this all day long. So just by arching and moving, and or not arching, but being in a different position, that's playful. Which is why being up like this is important as well. So one thing that I might do is go ahead and undo my sleep sack a little bit. And I could have done this before, or I could do it while I'm sitting her up. I'm going to help her. Then I'm going to turn her to the side so you can see my intent here. I've got that same little hold that we talk about, and I'm going to work on helping those shoulders. And then, hey, Sarah. Hey, big girl, can you come this way? I likely will have to come all the way in front here to have my visual gaze here, about 10 to 12 inches from her, so that she can find me in midline before she's going to be able to move her eyes to the side. Obviously, my doll, Sarah, doesn't move her eyes. But you'll see this little 20 degrees on both sides of horizontal, being able to, if you go slow, always start in the middle, and then have your face go to each side very slowly. And then you'll also find then, over time, that she'll actually be able to turn her head with that to look, right? Which is so awesome. So just visually engaging with this baby so that she can start activating all of her sternocleidomastoids, her SCMs, like all of the scalenes and upper traps and everything, to start moving her head on her own to help develop that head control, right? We're giving her that supported sitting, and we're just using our face to be down here in front of her to give her that input. We're going to include auditory with that, so voice with vision, to have both of those kind of stimulated as well, to be able to go to both sides. The other thing that I want to, make sure we talked about, that whole falling forward and what we could do about that from a therapeutic standpoint. We might need some therapy, but from a playtime, tummy time play, you might find that you need an extra little blanket. So just a blanket you have in the nursery, and depending on how big your little Sarah friend is how big your wrap or your roll might be. But tummy time is not just about, okay, I'm on my tummy. Tummy time is about getting in a supported position to be able to start working on head control. And at first they can just, kind of move their head and root a little bit and come around and, be able to start just turning their head from side to side. That's a survival thing, right? If you're prone with your arms down like this, so can you see the arms are down to her side and a face is here? It's a survival instinct to, in the next 20 to 30 seconds, move, and get these arms to come up like this so that you can lift your head up and turn your head for survival. Beyond that, then we want is a baby that can turn their head side to side and equally, and doesn't always have a preference to one side, and then of course can start coming up like this, and at 2 months of age more like this, at 3 months of age like this, and at 4 months of age on extended arms. To help them with that, keep in mind when a baby's first born and those first months of life, they have all this pelvic flexion, and so sometimes there's a lot of weight coming down here because their hips are up and all that gravity is pulling it down here, and you get this occipital extension. And so one of the things that we can do is put a little roll at the nipple level. So you can see my roll is right here at about the nipple level to help these arms come forward so that now I can shift this weight more posterior. And sometimes it's a matter of just helping the weight come posterior, because you can see just naturally with this doll, she's got posterior weight, so her head is able to come up a little bit easier. I a lot of times will have my hands here as well to help a baby kind of come. I'm always using the pacifier to help them root to both sides to turn their head for the pacifier. They're going to have times of active engagement, and then they're going to fall down and just suck on their hand and stuff, and that's great. It's a lot of energy to have 3 seconds of movement or even 2 seconds to hold their head up and then it comes back down. But that's all those activities that need to happen to help these front flexor muscles to develop to counteract the tight extensor muscles that we have, because we're not asking this baby to just use these muscles, we're asking this baby to engage all of these front muscles to be able to do this, to have a nice core, to work on their pectoralis muscles to be able to have head control. And so tummy time can easily be done in that way. Tummy time might be that you've got your baby in a tummy position and nicely supported in this position with their kind of shoulders underneath their nipple line like this, while you're documenting next to this baby. So the whole American Academy of Pediatrics saying that babies need to be predominantly supine to sleep is great, except for it's predominantly. So 51% of the time they should be, supine. But obviously, if they're awake and active and you're with them, they can definitely be prone, and they should be. So side lying and prone have so many benefits from a whole ability to have more normal movement and get rid of that tightness in the neck and the plagiocephaly and all of those things. So side lying and or once again, being prone while you're in the room documenting. Maybe you're in the room getting her milk ready. But all of these things are that you're teaching mommy and daddy, because they're the caregivers that are taking her home, and you want to help them incorporate these moments. Even 30 seconds, 3 minutes of tummy time is awesome. Tummy time is not something you do 10 minutes, once a day, but you can do it 30 seconds 10 times a day. And then you build up endurance to where this baby then is tolerating lots of tummy time, because that's what she prefers actually. So we're going to bring her up and out of tummy time. And once again, I've still just got that frontal pressure a little bit forward, never arching back like this. I'm never holding her like this. I'm as much as possible trying to get pelvic flexion, all of this to round forward to make her a happy human.
I certainly hope that these demonstrations and this presentation was helpful, and that as you go back and implement some of these ideas and skills in getting beyond the diagnosis, that you're able to take forward this idea of putting humanity back in healthcare, and that more importantly, that you're really able to realize how important you are in the start of this family, and that how you provide your care is going to be the core by which this family moves forward. So I thank you so much for listening, and I'm happy to take any questions.
If everybody would like to start sending in their questions via the chat, Carrie Ann is on and ready to answer them. I'll read them as they come in, if you'd like. And I did want to ask you if for the online, if we could get a copy of the PowerPoints as well, maybe a version that could be shareable.
Yeah, I sent that.
Okay, I might have it already loaded then.
Yeah,
okay.
I think it's loaded. It's got 2 slides to a page. Yep, so you should
yeah, you got it to me. That's right. There's been so many. Thank you.
Sure.
Okay, so the first question is, do you have an online video to show clients?
I do not, and shockingly, it's probably because I prefer one-on-one or just that, back and forth to have that personal relationship. So we used to have a massage video, and I just need to redo it, so I don't have anything like that at this point. In terms of the other caregiving activities like bathing and skin to skin, we do have a DVD, and you can license those to just be able to show both staff and parents. So that's an opportunity for kind of education for everybody.
Okay, next question. What are your recommendations for skin to skin rooming with a mom that tests positive for COVID but no symptoms?
So I'm not going to give any recommendations for that because I don't feel like I'm qualified, to be honest. I would have to divert to whatever your state governor's COVID regulations are. I live in the state of Ohio, and we are very much mandated by our specific governor's recommendations and the CDC recommendations. So I just feel like I need to stay away from that because infection control is not my area of expertise. In regard to skin, absolutely positively as much as possible, as long as possible, as frequently as possible, but I can't respond to the COVID situation. Sorry.
Okay, next question. With hospitals moving to baby-friendly status and non-pacifiers, what are your thoughts on promoting a more positive environment for baby, as this seems a bit of an oxymoron?
So, so I 1000% believe that we should all be talking to family members about, and our staff, to be honest, to help everybody understand that sucking is self-regulation and that it's not about the oral motor and that you don't get nipple confusion by sucking on a pacifier. And so if I've got a mom, you know, I'm usually the one that gets that call from that nurse that says, hey, we've got a mom who's like refusing the pacifier, or you know, we can't do a pacifier. Keep in mind I work in intensive care nursery, and so in terms of the requirements for not using the pacifier from a baby friendly standpoint is a little bit different. But irregardless, I just talk to the people and help them understand that they can use a dry breast, they can use a gloved finger, they can use their own finger. Like, I don't care what the baby's sucking on. Loved it back in the co-bedding days when the babies would suck on each other's noses and faces. But it's important for a baby to have the opportunity to suck.
All right, we're waiting for a few more questions to come in.
Okay.
Oh, Sarah, who asked the question, said, thank you. That's great info.
Oh, good.
All right, any more questions, anybody? Give it another minute. Oh, here we got one here. Up to what age or months can infant massages, up to what age or months can infant massages can be applied?
So there is a difference between like infant massage and what I teach is a neonatal massage. So what I teach is geared toward babies like NAS or other babies in a intensive care nursery, or that have, you know, they're not just a normal newborn that is now 2 months old or 3 months old, because the strokes are vastly different. The massage I teach is neonatal, which means it's all about parasympathetic nervous system. So that is always appropriate long-term because it's just parasympathetic. As a baby gets older and or developmentally able to handle more, and the parent. So keep in mind when you're looking at massage, the difference between neonatal massage and infant massage is not just about the baby, it's about the family. So families that have babies in intensive care nursery or NAS are just a different family than when you're at home. So massage is really something, you know, there's studies about adolescents having massages that, you know, it helps decrease anxiety and all kinds of things for different diagnoses. So as adults, we get massage. The benefits for massage all the way through, from infancy all the way through, are just really powerful. So I don't know that there's an age to stop. It's more about what kind of massage to do for what developmental stage of that baby.
Next question, should swing time be limited?
I definitely believe that a baby should not literally every 3 hours when they get done eating be put in a swing. And I don't think that really, you know, we're such a container society. We're always putting our babies in seats, and because we're always on the go. So I think that it's less about the vestibular input that's a problem. It's more about the fact that and I'll pull Sarah back out, when you've got Sarah and she's in a swing, she's going to end up with her head falling to the side from a gravity perspective. And so we're just facilitating this every time. They tend to get curved on one side, whichever side that is. And so we're just causing some musculoskeletal stuff. So I think we should definitely limit it and mix it up. You know, if you're going to be in the bed on your back this 3 hours and then you eat, and now you're going to be in the swing the next time, but let's not go back in the swing for 6 hours or repeatedly all day long.
Okay, any more questions? That might have been the last one.
Okay, awesome.
Well, we want to definitely thank you so much for participating in the Texas NAS Awareness Month. Since we had to change from a live conference to virtual, we truly appreciate your presentation and you sharing all this wonderful knowledge with our group.
Oh, I'm happy to do it. And if anybody has extra questions, they can just reach out to me. So
I'll make sure if they ask me, I'll get them to you. We really appreciate it. And everybody's saying thank you, wonderful job. So have a great day and stay safe.
all right, you as well. Thank you.